Welcome back to the deep dive. Today we are undertaking a really critical deep dive into one of the most clinically challenging areas in all of surgery, bone and joint infection.
It really is. And if you're preparing for exams or you're managing patients in orthopedics or you just want to understand why a seemingly simple infection can spiral into a multi-year surgical nightmare, then this is for you.
Exactly. We are drawing the highest yield material from Chapter 43 of the 28th edition of Baily and Love Surgery.
And we should be really clear about our mission here. This isn't a word-for-word reading of the textbook.
No, not at all.
It's our interpretation, a simplification. Think of it as a ready reckoner, something to give you the mental roadmap and the critical concepts you need to anchor this huge topic down.
So you should absolutely use this deep dive alongside your primary reading.
Please do.
And the context for this is, well, it's urgent. Infection of bone, osteomyelitis, is ancient. I mean, it's a surprisingly cool fact, but we found evidence of it in dinosaur fossils.
Which is incredible to think about. But while the disease is old, the medical and economic burden today it's new and it's growing, and it's powered by modern human factors.
What do you mean by that?
Well, we're living longer, the population is aging, and crucially, we're performing exponentially more orthopedic procedures, especially joint replacement.
Right. Every single implant creates a potential new home for bacteria.
A perfect harbor for infection. And you compound this with rising rates of comorbidities, diabetes, obesity, malnutrition, immunocompromise, and you have the perfect storm.
The scale is staggering.
It is. Prosthetic joint infection, or PJI, was estimated to cost the U.S. healthcare system over $1.5 billion in 2020 alone.
$1.5 billion.
That's a massive resource-draining problem. It demands precise, coordinated management.
$1 billion bug problem. I think that staggering context really tells you why getting the diagnosis and the management right is so critical. So to help us navigate this, we'll be building up several mental anchors and using some simple metaphors to help distinguish and recall these concepts.
Let's do it.
Okay, let's start at ground zero. The definition. Osteomyelitis. If we break down the word, it's pretty straightforward, right?
It is. Osteo for bone, myelos for marrow, and itis for inflammation. But the clinical presentation is anything but simple.
It's really a tale of two diseases.
Exactly. The clinical presentation really defines the whole approach. You have acute infection, which fits that typical picture of a bacterial invasion, rapid onset, major systemic upset, high fever, local inflammation, and just copious pus within the bone marrow space.
But the defining trait of bone infection is its ability to just slip into this chronic, insidious state.
That's the real danger. Chronicity happens when you fail to completely eradicate that acute infection. Maybe the patient didn't get enough antibiotics, or more commonly, the infection just digs in, it settles into the non-viable structure of the bone itself.
And it could just smolder there for years.
For decades. Chronic osteomyelitis is characterized by slow destruction, loss of function, and often just slowly evolving local symptoms without that high fever or systemic illness. The literature suggests up to a third of acute cases, if they're not treated properly, transition to this pattern.
This difference between acute, full-blown infection and chronic, smoldering destruction brings us to our first major concept, our pathology anchor, the bone battlefield.
It's a great metaphor because bone is unique. It can't swell or easily bleed away an infection like soft tissue can.
It's a rigid box.
It's a rigid box. So when bacteria invade the marrow, pus forms and the pressure inside skyrockets. This pressure forces the pus outwards, lifting the covering membrane, the periosteum, and this whole process just strangles the local blood supply.
And bone cells are very sensitive to losing their blood supply.
Incredibly sensitive. So the bone tissue dies, and it dies quickly.
And that dead bone doesn't just dissolve, does it? It stays there like an infected island.
It stays, and that structure is the first key term you have to know, the sequestrum, the dead territory.
Sequestrum.
It's a segment of devascularized necrotic cortical bone. It acts as a permanent bacterial scaffold because it has no blood supply. That means your host immune cells and your systemic antibiotics can never, ever reach it.
The image of a surgeon removing a large, irregular sequestrum from a femur is a classic one in orthopedics for a reason.
It's visceral. It is biologically and medically dead, and its physical presence is the absolute hallmark of chronic osteomyelitis.
Okay, so the sequestrum is the dead target. How does the body try to contain it?
It tries to build a wall around it, and that wall is our second key term, the involucrum, the fortified wall.
The involucrum.
This is new, often disorganized bone laid down by that surviving elevated periosteum around the infectious site. The body is essentially trying to contain and wall off the infection. It's a desperate act of self-quarantine.
On an X-ray, that would look like thickened, irregular bone.
Exactly. Sclerotic, dense bone trying to form a barrier.
That's a striking image. A fortified wall built around a dead, infected territory.
Yeah.
But if the body creates this involucrum to wall it off, why does the infection persist? Why does it fail?
That's a great question. It fails because it's incomplete. It's often poorly vascularized itself. But more importantly, the bacteria have a third, even more sophisticated defense mechanism.
The biofilm.
The bacterial fortress shield. This concept has completely revolutionized how we understand chronic infections.
So break it down. What exactly is a biofilm, and why is it so lethal to any treatment?
Okay, so a biofilm is a complex, self-organized community of bacteria. They can be stuck to the sequestrum, the involucrum, or, crucially, an artificial implant.
Like a hip replacement.
Exactly. These bacteria encase themselves in a matrix, mostly made of self-produced polysaccharides. Just think of it as a microscopic, slimy fortress wall.
And this shield works in two ways.
It does. Structurally, it physically prevents large immune cells, like macrophages, from getting to the bacteria. But more critically, the bacteria inside the biofilm shift their metabolic state.
They sort of go to sleep.
They basically do. They enter a near-dormant, slow-growing state. And this physiological change makes them highly resistant to systemic antibiotics.
Why is that?
Because most of our antibiotics, especially the common ones like beta-lactams, work best when bacteria are rapidly multiplying and building cell walls. If the bacteria are effectively asleep inside their fortress, the antibiotics just pass right by, completely useless.
And that explains the absolute non-negotiable principle.
Yeah.
You cannot cure chronic bone infection with antibiotics alone.
You cannot. You must surgically remove the physical dead tissue, the sequestrum, and you have to mechanically disrupt that biofilm shield. If you leave the physical anchor point, you leave the infection.
Let's talk about the microbiology then, the usual suspects. We need to distinguish between infections in healthy native bone versus those on artificial materials.
This is our virulence versus implant anchor. When infection hits previously healthy native tissue, the pathogen usually needs to be highly virulent, really aggressive to overcome healthy defenses.
And the number one culprit is?
The gram-positive monster, Staphylococcus aureus. Always think S. aureus. It produces toxins that cause rapid tissue necrosis. It's the most common cause globally.
But if you introduce an artificial surface like a fracture plate or a knee replacement, the rules change completely.
They flip entirely. The implant surface is a ready-made structure for biofilm formation. It makes it susceptible to bacteria that are normally just harmless skin bugs. The biggest example here is coagulus-negative staphylococci, or CoNS.
Like Gophylla epidermidis.
Exactly. These are low-virulence bugs, but they are absolute experts at making biofilm on plastic and metal.
I remember learning about a particularly tricky one, especially in shoulder replacements.
Yes. For prosthetic shoulder infections, we're increasingly focused on Cutibacterium acnes, which used to be called Propionibacterium acnes.
Right.
This is another extremely slow-growing, low-virulence organism. It's why we need that prolonged 10-day culture incubation period we'll talk about later. It's so often missed in standard culture protocols.
And there are also specific bugs linked to specific patient histories that we have to remember.
Absolutely. The source material highlights several key links. For patients with sickle cell disease, think Salmonella. Their abnormal blood vessels make them uniquely susceptible.
Okay.
In very young children, especially those under 4 years old, you have to consider Kingella kingae. It's a crucial, easily missed cause of septic arthritis and osteomyelitis.
And the diabetic foot.
The diabetic foot is a microbiological soup. The infections are often polymicrobial, mixing aerobic and anaerobic bacteria. You'll see gram-negatives like E. coli, Enterococci, and especially if there's been prior hospital exposure, Pseudomonas. You have to cover that whole complex mix empirically.
Fantastic groundwork. We've defined the disease. We've got the pathological triad sequestrum, involucrum, biofilm, and the core microbiology. So here's our first check-in. Check-in question 1. If you, the learner, are reviewing the X-ray of a 55-year-old patient, they've had a chronically discharging sinus for 3 years after an open fracture fixation. The radiograph shows thickened, irregular bone surrounding a central, darker segment of cortical bone. What are the 2 key pathological structures you are seeing? If you need a moment, just rewind and listen again to the pathology anchor.
The answer is the sequestrum. That's the centrally dead, non-viable bone. And the involucrum, the body's thick, reactive peripheral bone laid down by the periosteum. If you can recognize those two structures, you have correctly diagnosed a chronic bone disease that needs surgery, not just antibiotics.
All right, let's move on to diagnosis. In acute septic arthritis, it can be quick, but for chronic osteomyelitis and PJI, it's famously subtle. Let's talk about the limited use of standard blood tests first.
Yes, we need a firm warning anchor here for inflammatory markers, ESR, CRP, and white cell count.
But we always check those.
We do, and they're great for acute systemic inflammation. But, and this is a big but, they are neither sufficiently sensitive nor sufficiently specific to reliably rule infection in or out, especially in chronic disease.
So a normal CRP doesn't mean no injection.
Not at all. I've seen countless cases of proven, significant chronic osteomyelitis with a perfectly normal CRP. Relying on a normal blood test can lead to catastrophic delays in diagnosis.
Okay, so we can't trust the systemic markers, especially with low-grade infections hiding in a biofilm. What about newer, localized markers for prosthetic infections?
For PJI, this is where specialized testing on the synovial fluid, the fluid you pull right out of the joint, is critical. We now have sophisticated markers like synovial fluid alpha-defensin and calprotectin.
Tell me more about alpha-defensin.
It's an antimicrobial peptide. It's part of our innate immune system, and it's released by the primary cells fighting the infection, the neutrophils or PMNs.
Yeah. So it's a direct product of the local fight.
Exactly. PJI causes a massive surge of neutrophils into the joint space, so the concentration of alpha-defensin shoots up. It offers incredibly high sensitivity and specificity compared to a generalized blood marker.
That's a huge diagnostic leap. Now let's move to imaging. How do the different types help map out the infection?
Imaging tells a delayed story. That's a key concept. Plain radiographs, or X-rays, are terrible for early acute diagnosis. They are often completely normal for the first few days.
Because it takes time for the bone destruction to show up.
Exactly. But they become critical tools over time. They'll show you implant loosening, lysis, or the classic sequestrum and involucrum. They map the destruction.
If the patient is acutely unwell and we need to find a collection of pus quickly, what's the go-to?
That's the domain of ultrasonography, the collection hunter. It's fast, it's non-invasive, and it's ideal for identifying soft tissue abscesses or joint effusions. And crucially, it's the perfect tool to guide your needle aspirations to get a clean sample for culture.
And for planning the actual surgery, the debridement, especially with cortical bone problems.
For that, you need the detail of a CT scan, the cortical mapper. CT is much better for seeing small sequestra, for assessing fracture union and mapping out the cortical erosions. An axial CT gives the surgeon a perfect roadmap for excision.
And the gold standard for soft tissue and marrow.
That's MRI, the soft tissue gold standard. As long as there isn't too much metalwork causing artifact, MRI is the most sensitive and specific test. It shows you everything: the medullary infection, the surrounding soft tissue involvement, any collections.
But there's a well-known caveat with MRI that surgeons have to remember, isn't there?
Yes, MRI is so sensitive that it can overestimate the extent of active infection. You get a lot of reactive edema, just simple inflammation around the infection that lights up intensely on the MRI.
So it looks worse than it is.
It can. The surgeon has to clinically correlate the MRI findings and distinguish between reactive inflammation and actual definitive purulence in the operating room.
What about nuclear imaging?
Standard isotope bone scans are pretty non-specific, largely obsolete. The real utility is in 18-FDG PACE-CT. This uses a tracer that lights up areas of high metabolic activity, which active infection is. It's very useful for pinpointing the exact site of infection in chronic cases, which helps surgical planning.
But it can't tell the difference between a loose, non-infected implant and an infected one.
Correct. It can't reliably distinguish aseptic loosening from infection.
All this imaging, though, is useless unless we achieve the core diagnostic goal, capturing the pathogen.
This is the most critical part for successful treatment. We need reliable microbial data, and the first anchor here is about what not to do. The unreliable swab anchor.
Taking a swab from the draining sinus.
Exactly. Superficial swabs are fundamentally unreliable and misleading. They reflect surface contaminants, skin flora, not the deep pathogen embedded in the biofilm. Basing treatment on a superficial swab is a recipe for failure.
And the other common error: starting antibiotics too early.
The antibiotic problem. If you start antibiotics before you get your samples, even for a short time, you can get falsely negative cultures. This leads to culture-negative infection, which is incredibly difficult to manage.
So what's the rule?
For any stable patient undergoing elective sampling for a chronic or prosthetic infection, the guidance is non-negotiable. Stop all antibiotics for at least 2 weeks beforehand to maximize your diagnostic yield.
And for getting the samples themselves, there's a very strict protocol now, especially for prosthetic joints.
This is the 5-sample rule anchor. It's an absolute requirement. You must take at least 5 separate tissue samples from the infected area.
And the technique is key.
It is. Each sample must be taken with a separate, fresh, sterile instrument, and the samples must be kept in culture for at least 10 days, not the standard 48 hours.
Why 10 days, and why 5 separate samples?
The separate instruments are to avoid cross-contamination. The 10-day incubation is specifically to catch those slow-growing biofilm organisms, like C. acnes. They just take time to grow out in the lab. And to confirm PJI, you need to grow the same organism from at least 2 of those 5 samples.
What if the cultures are still negative? Can the pathologist help?
Absolutely. Histopathology confirmation is vital. Histology confirms infection by identifying a neutrophilic infiltrate, specifically 5 or more polymorphin nuclear neutrophils, or PMNs, per high-power field. Their presence confirms the inflammatory battle, even if the culture was sterile.
Okay, that clarity is central. Let's move to management. We've established these are complex infections,
Which demands a complex, coordinated effort. Successful treatment is always a multidisciplinary team, MDT, approach. It's never just a surgery problem.
You need orthopedics, plastics, infectious diseases.
Pharmacy, specialized nursing, psychological support, it's a whole package of care.
And before the patient even gets to the operating room, the source material stresses one critical step.
The preoperative optimization anchor. Surgery on an unhealthy patient leads to failure. Cure rates are significantly higher if you meticulously address all the modifiable risk factors,
Like getting their diabetes under control.
tight glycemic control, optimizing nutrition, mandatory smoking cessation, addressing peripheral vascular disease, all of it.
And the emotional toll has to be addressed too.
It is huge. A chronic osteomyelitis or a 2-stage revision for a PJI is a journey that can last a year or more. It involves multiple surgeries, long antibiotic courses, prolonged disability. You need comprehensive counseling and psychological support built into the pathway.
So let's define the critical operative goals. What are we trying to achieve in the OR?
There are 6 foundations for a cure. 1, good exposure for deep sampling. 2, radical excision of all infected and non-viable tissue, everything. 3, starting IV antibiotics, but only after you have your samples.
Okay, right.
4, achieving stable bone fixation. 5, managing the dead space you've created. And 6, ensuring you have reliable, healthy, soft tissue cover, which often means bringing in the plastic surgeons.
That radical excision number 2 sounds like the hardest part.
It is the gold standard. If you are aggressive in your debridement, your cure rate goes up. If you leave even a tiny piece of sequestrum behind, you've left the anchor point for the biofilm, and the infection will come back.
Let's zoom in on antibiotic timing again. Is there ever a time you must start antibiotics immediately?
Yes, we use the timing anchor for this. Only 2 situations warrant immediate empirical antibiotics. If the patient is in septic shock, or if they have a rapidly advancing infection like necrotizing fasciitis, where delaying treatment would risk life or limb.
And in those cases?
You take blood cultures, aspirate pus if you can, and then you start the antibiotics.
But for the vast majority of stable, chronic, or elective PJI cases,
You delay the antibiotics until the patient is in the operating room and you have taken your definitive operative samples. That disciplined delay is absolutely necessary to get the right bug identification.
and if you have to start empirically, what's the strategy?
It depends on the scenario. For a community-acquired infection, something like coamoxiclav or ceftriaxone to cover staph and strep is often fine.
But for hospital-acquired or more complex cases,
You broaden the coverage aggressively. Add vancomycin for likely MRSA. Consider meropenem or ciprofloxacin for resistant gram-negatives like Pseudomonas. You have to think about what they've been exposed to.
finally, the duration and route of therapy. The old dogma was weeks and weeks of IVs.
That changed dramatically with the Oviva trial anchor, the oral revelation. This landmark trial showed that for many patients, oral therapy is equally effective as prolonged IV courses.
As long as certain conditions are met.
Right. 2 essential conditions. 1, the organism must be proven to be susceptible to the oral agent. And 2, the patient has to be able to reliably tolerate and adhere to the oral regimen.
That's huge for the patient experience.
It's a game changer. It means they aren't tied to a PICC line for months. It reduces hospital stay, cost, and complications, and the trial showed non-inferiority in cure rates.
Let's pivot now to native joint septic arthritis, which you flagged as a surgical emergency. Why is it so much more urgent?
Because of the articular cartilage. Cartilage is an innocent bystander in the joint space. When bacteria invade, they release massive amounts of toxins and lytic enzymes proteases directly into the synovial fluid.
And that destroys the cartilage.
Incredibly rapidly, it causes irreversible destruction, a process called chondrolysis. Every single hour the joint remains infected risks permanent damage and severe arthritis for the patient.
Who are the high-risk patients we need to watch for?
Extremes of age, so neonates and very old. And anyone with pre-existing joint problems, patients with rheumatoid arthritis are highly susceptible.
Because they're often on immunosuppressants.
Exactly. And their joint lining is already inflamed. Other risks are diabetes, HIV, and any recent joint instrumentation, like a steroid injection.
And where does it typically strike? We need a location anchor here.
In neonates and infants, it's most commonly the hip. And that's dangerous because of the risk to the blood supply. In adults and older children, it's the knee. It's just a large target.
Clinically, what is the definitive sign, even if the patient doesn't have a raging fever?
It's an acutely hot, swollen, painful single joint. But the definitive red flag is the mechanical restriction. The patient holds the joint in a position of comfort, often slightly flexed, and any active or passive movement, even a gentle attempt to straighten it, causes severe, excruciating pain.
That severe pain on movement must override everything else.
Absolutely. Fever is absent in up to a third of adults. A normal CRP or lack of fever should never delay investigation if that severe pain on movement is present. That clinical sign is the most reliable predictor.
So diagnosis is rapid and mechanical. Get the fluid out.
Mandatory. You aspirate the joint. You're looking for a highly inflammatory fluid, a white cell count typically between 50,000 and 150,000, with an overwhelming predominance of neutrophils over 90%. If the fluid is frank pus, you have your diagnosis.
Given the urgency, the management priority anchor is clear. Prompt surgical drainage.
Within hours. This is a true surgical emergency. You have to physically wash out the bacteria and critically dilute and remove those lytic enzymes that are dissolving the cartilage. Delaying even 24 hours can be catastrophic for the joint.
What does that surgical washout involve?
It can be done arthroscopically for a knee or via an open arthrotomy for a hip. The surgeon uses massive volumes liters and liters of warm saline or Ringer's solution to flush the joint.
And there's a crucial detail about the fluid itself.
Yes, antiseptics must be avoided. Things like iodine might seem useful, but they are highly toxic to the cartilage cells and will actually compound the damage. You rely on mechanical removal, not chemical sterilization. The surgeon also often performs a synovectomy, removing the inflamed joint lining.
And antibiotics after surgery.
Total course is usually 3 to 6 weeks, starting with IV. But thanks to the OVITA evidence, we can often transition to oral therapy quite quickly based on susceptibility.
Okay, let's apply this with a case. Case study and check in too. Imagine a 72-year-old male, a bit frail, history of diabetes. He comes into the ED with an acutely painful left ankle. It's a bit swollen. No chills, mild temperature. But when the nurse tries to move his foot to reposition him, he cries out uncontrollably. Based on what we've just discussed, what is the definitive next step, and why do you need to call the surgical team immediately?
The clinical picture, that severe pain on movement in a high-risk patient, is screaming possible septic arthritis. The definitive next step is emergency joint aspiration and immediate surgical washout. The reason for urgency is to save the joint cartilage from chondrolysis. You cannot wait for the CRP. You cannot wait for the culture results. That joint must be drained right now.
Okay, let's move on to the chronic challenge. Implant-related infections, PJI and FRI. You said the timeline is everything for PJI. Let's map that out.
We use the timeline anchor to categorize the infection. It gives us clues about the bug and the best strategy.
Let's start with the quick ones.
Early infection. This is less than 3 months post-op. These are almost always acquired during the surgery itself and are caused by virulent organisms, usually S. aureus. They present acutely, wound discharge, cellulitis, significant pain.
Next, the more subtle onset.
Delayed infection. This is between 3 and 24 months. This is your classic low virulence, biofilm-driven infection. The culprits are things like coagulus-negative staph or C. acnes. The presentation is insidious, just chronic joint discomfort or mild pain.
And finally, the late infections.
Late infection. This is more than 2 years after the surgery. Here, the implant has been stable for years. The infection is usually from hematogenous spread bad bacteria traveled through the blood from a remote site like a dental abscess or a UTI and seeded the implant.
To diagnose PJI definitively, we use the EBJI's criteria.
Yes, the EBJS criteria anchor provides a standardized roadmap. Infection is confirmed if you have a major criterion, like a sinus tract communicating with the joint, or if you grow the same organism from at least 2 separate deep cultures.
And the minor criteria.
They include things like a high synovial fluid white cell count, specifically over 3,000 elevated markers like alpha-defensin or positive histology. It's a robust framework.
Now for the hardest decision in orthopedics, save the implant or remove it.
The decision hinges on one fundamental law, or crucial principle. A loose infected implant must always be removed. If the implant is no longer mechanically sound, it is not salvageable.
But if the implant is well fixed, you might attempt to save it.
Yes, that's called DARE, debridement, antibiotics, and implant retention. DARE is only for well-fixed prostheses, and ideally only for early infections. It requires meticulous surgery, radical excision of all soft tissue, exchanging all modular components, and excellent soft tissue cover.
But the success rates aren't guaranteed.
Not at all. They're variable, maybe 50–70%, and the success rate plummets if the cause is S. aureus or it's a delayed biofilm infection. The antibiotic course afterwards is also demanding, often 6 weeks of IV followed by 6 months or more of oral suppression. It's a calculated risk.
So if the implant is loose or DARE is too risky, we move to the gold standard.
Which is the 2-stage joint revision. Stage 1 is a radical operation. Remove the entire implant, all the cement, all foreign material, and aggressive debridement. Then you put in a temporary antibiotic-impregnated spacer.
What's that made of?
Usually bone cement loaded with high concentrations of antibiotics like vancomycin or gentamicin. It maintains the joint space and, more importantly, delivers extremely high local antibiotic concentrations right where they're needed. The patient then gets 6 weeks of systemic IV antibiotics.
And then stage 2.
That's the reimplantation of a new sterile prosthesis, but only once we're confident the infection is gone. This is the most reliable curative procedure.
Why do some surgeons favor a single-stage revision then?
It's gaining traction because it avoids a second major surgery. It's reserved for carefully selected patients, those with less florid infections, excellent soft tissues, and organisms that are highly susceptible to antibiotics. It's also considered for frail patients where a second anesthetic is a high risk.
And if a cure just isn't achievable?
Then you have salvage options. For the hip, that might be a girdle stone excision arthroplasty, where you remove the femoral head, creating a pseudojoint. It leaves a shorter but functional limb. For patients too unfit for any curative surgery, long-term suppressive antibiotic therapy is an option, though recurrence is high.
Let's touch on fracture-related infection, FRI. You said instability is the key problem here.
Instability is the crisis. An infected fracture will not heal. You have to achieve stability to get healing and cure.
Okay, scenario 1. An unhealed fracture, but the metalwork is stable.
You manage this like a DARE. Aggressive debridement, manage the dead space with local antibiotic carriers, get good soft tissue cover, and retain the stable metalwork to allow the bone to heal.
Scenario 2. The fracture is healed, but the implant is infected.
That's an easy decision. Remove the implant, debride the site. The stability problem is solved.
And scenario 3. The crisis. An unhealed fracture with unstable fixation.
This is the instability crisis anchor. You cannot tolerate an infected, unstable fracture. The unstable implant must be removed, radical excision performed, and the bone must be immediately re-stabilized. This often means swapping an internal plate for an external fixator or using an antibiotic-coated nail. It's a huge reconstructive challenge.
Now, for chronic osteomyelitis, the long haul, we've said blood tests are often normal. Diagnosis is surgical. How do specialists classify this to choose the right treatment?
We use the BACH classification, the roadmap to treatment. This is essential because it forces you to consider 4 interlocking factors that determine success or failure.
Let's break down the acronym BACH.
B is for bone involvement. B1 is cavitary, a simple localized hole. B2 is segmental loss, where a whole section of bone is gone. B3 is whole bone involvement, which is extensive.
A is antimicrobial profile.
Right. A1 is a sensitive bug. A2 shows moderate resistance. A3 is highly resistant, sometimes only sensitive to toxic drugs.
C is for coverage of soft tissue.
This is the plastics challenge. C1 means you can close the wound directly. C2 means there's a large defect requiring a complex flap for coverage.
And finally, H is host status.
This is the patient's ability to heal. H1 is a fit host. H2 has poorly controlled disease like diabetes. H3 means the patient is medically unfit for aggressive surgery or declines it.
That roadmap clearly separates the simple cases from the nightmares.
Exactly. An uncomplicated case, say a B1A1C1H1, can be treated with local excision and direct closure. A complex case, a B2 with A3 resistance and a C2 defect, is a completely different disease.
What does that require?
Those cases require a major reconstructive shift. If you have segmental destruction, the curative approach is a radical segmental resection. You cut out the entire infected segment of bone, leaving a huge gap.
How do you fill that gap?
The primary method is the Elizarov method. This uses an external ring fixator that stabilizes the bone ends while allowing you to slowly pull them apart, a process called distraction osteogenesis. As you distract, new bone forms in the gap.
Regrowing the bone.
Essentially, yes, it's meticulous, long-term work. The patient might be in the frame for a year or more, but it offers a limb salvage option where the only alternative might be amputation.
How long are antibiotics prescribed for these chronic infections?
Typically 6 to 12 weeks of targeted systemic antibiotics after the debridement, and we're seeing a huge rise in the use of local absorbable antibiotic carriers, pellets, or beads loaded with antibiotics that you put right into the bone defect.
Let's move to diabetic foot infection, DFI. A massive cause of morbidity.
It's driven by a vicious triad. Neuropathy, so the patient can't feel trauma. Vascular insufficiency, so there's poor healing and poor antibiotic delivery. And immune defects. Up to a fifth of cases end in amputation.
How do we diagnose osteomyelitis in this setting?
It's often clinical. Inflammatory markers are highly unreliable. MRI is the most sensitive imaging, but clinically, the low-tech test is critical. The probe-to-bone test anchor. If you can gently pass a sterile, blunt probe through an ulcer and it grates on hard bone, that strongly confirms underlying osteomyelitis.
And the microbiology is complex.
Very. It's polymicrobial. You have to cover staph, strep, gram-negatives, and Pseudomonas is overrepresented. Empirical therapy has to be broad.
What's the ultimate management priority in DFI?
The vascular supply. You must optimize their vascular status with angioplasty or bypass and get meticulous glycemic control before any extensive bone surgery. Operating on a poorly perfused foot is futile.
Finally, we have to touch on musculoskeletal TB, which is resurging.
It is, driven by migration and immunocompromise, especially HIV. It's a chronic granulomatous infection.
And where is the definitive location anchor for TB in the skeleton?
The spine. Half of all TB cases affect the spine, leading to discitis and vertebral body collapse, what we call Pott's disease.
And this requires specialist drug management.
Absolutely. And MDT is essential. HIV screening is mandatory. The drug regimen is prolonged and complex, and adherence is key.
What is the anchor for that regimen?
The standard sensitive regimen lasts 6 months. It's the Ripery regimen anchor. The first 2 months are 4 drugs: rifampicin, isoniazid, pyrazinamide, and ethambutol-RIPE. Then it's followed by a continuation phase of just rifampicin and isoniazid, or RI, for the remaining 4 months.
So the surgeon's role is limited.
It is. Surgery is generally reserved for mechanical problems, spinal instability, neurological decompression, or getting a diagnostic biopsy. The cure is fundamentally driven by the chemotherapy.
Okay, final check-in for our listeners. Check-in question 3. A 40-year-old patient has an infected non-union of the tibia. Sampling reveals bacteria resistant to all first-line antibiotics, A3. The infection has destroyed a 10 centimeters segment of bone, B2, and the soft tissue defect means direct closure is impossible. What broad classification does this patient fall under according to the BACH system, and what specific complex reconstruction method will likely be necessary for limb salvage?
That is a classic BACH complex case. It's defined by segmental bone loss, high resistance, and poor soft tissue cover. The management requires radical segmental resection, and given that 10-centimeter bone gap, the specific reconstruction method necessary is the Elizarov method using distraction osteogenesis.
That clarity, using the BACH system to decide if you need a simple debridement or a year-long marathon, is the mastery point of this chapter.
To synthesize the most critical concepts from Chapter 43, let's recap our 5 pillars. 1. The pathological triad of sequestrum, involucrum, and biofilm.
The definition of chronic disease.
2. The absolute necessity of deep, multiple samples, following the 5-sample rule and the 10-day culture rule. 3. Your PJI strategies. Well-fixed implant, consider a risky dare. Loose implant, 2-stage revision is mandatory. 4. The severity of septic arthritis, which requires immediate surgical washout to protect the cartilage. And 5. The comprehensive BACH classification, making sure you address bone, bugs, cover, and host status before you even start.
This deep dive has given you the conceptual shortcuts and the anchor points. But as we've seen, the complexity demands nothing less than a thorough reading of the full chapter. Seeing these principles applied clinically is the final step to true understanding.
And let me leave you with a final thought on the future of orthopedic infection. We've talked about the success of local antibiotic carriers, those pellets delivering huge drug concentrations directly into the bone.
Mhm.
Considering that the biggest hurdle is the systemic resistance induced by the biofilm's dormant state, how might this highly localized, high-concentration strategy evolve to eventually replace or dramatically reduce the need for long, toxic, systemic, intravenous antibiotic therapy in the next decade? It really questions the whole idea of a systemic fight against what is fundamentally a localized fortress.
That potential future, treating the problem locally instead of systemically. That's a fascinating thought. Thanks for joining us for the deep dive.